Hello viewers, I am Dr. A. Arif Yezdani, Professor and Director in the Department of Orthodontics and Dentofacial Orthopedics. I am here once again with yet another topic in the subject of orthodontics and dentofacial orthopedics. The topic I am going to deal today would be removable appliances. And when I say removable appliances, I mean the simple removable appliance which is made up of the acrylic base plate, and then we have the retentive clasps as also the active components, namely the labial bow, the screws, etc. So what are the indications of a removable appliance? Removable appliances bring about tipping tooth movement, and these tipping tooth movements are used for the correction of individual tooth malpositions or arch expansion. These removable appliances can also be used for retention. The last part, which is mentioned as the growth modification during mixed dentition period, well, this is done with the removable functional appliances. I am not going to deal with the removable function appliances, but rather the removable orthodontic appliance which an UG as also a PG need to know. So what are the advantages of removable appliances? Removable appliances can be removed on socially sensitive occasions. Of course, they are fabricated in the lab. And if we think about the removable function appliances, they do bring about some amount of growth modulation. So what are the disadvantages of removable appliances? The patient compliance is compromised, complex tooth movements impossible, bodily tooth movements impossible, and extraction spaces can't be closed effectively with removable appliances. So what are the components of a removable appliance? We have three components, namely active components such as the labial bows, springs, screws, elastics. We have the retentive components, which are the different types of clasps. And then we have the base plate made up of cold cure or heat cure acrylic, which houses the active and the retentive components. So there are a host of clasps which are used for retention. I shall just enumerate them and then go into the details of each. We have the C clasp or the circumferential clasp, or we call it the 3/4 clasp, which is made up of 19 gauge wire, or you can say 0.9 millimeter stainless steel wire. The Jackson's clasp is made up of 19 gauge or 0.9 millimeter stainless steel wire. The triangular clasp is made up of 21 gauge or 0.7 millimeter stainless steel wire. Schwartz single or continuous arrowhead clasp is made up of 21 gauge or 0.7 millimeter stainless steel wire. The Adams clasp and its modifications is made up of 21 gauge or 0.7 millimeter stainless steel wire. The South End clasp is made up of 21 gauge or 0.7 millimeter stainless steel wire. The ball end clasp is made up of 21 gauge or 0.7 millimeter stainless steel wire. The eyelet clasp is made up of 21 gauge wire or 0.7 millimeter stainless steel wire. The Duising's clasp is made up of 21 gauge or 0.7 millimeter stainless steel wire. The delta clasp is made up of 21 gauge wire or 0.7 millimeter stainless steel wire. And finally, the crozat clasp is made up of 18 gauge wire or 1 millimeter stainless steel wire. Now, if you see these clasps, most of them are made up of 21 gauge wire or 0.7 millimeter stainless steel wire. And the few which are made up of the 19 gauge would be the C clasp and the Jackson's clasp, whereas the crozat clasp would be made out of an 18 gauge or a 1 millimeter stainless steel wire. Now, we shall go into the details of each clasp. The C clasp is made up of 19 gauge, as we had already said. Now, where does it take its retention from? It takes its retention from the distal as also the buccal undercut, and then it goes over the occlusal embrasure and ends as a retentive tag, and that is embedded in acrylic. We can have it as a distally touching, or you can also have a mesially approaching clasp the other way around. We have the Jackson's clasp. Here it takes advantage of the buccal undercut more so at the cervical region. And then if you were to adapt it well, it can also take advantage of the mesial and the distal undercuts of the molar too. And then the tags are then retained in acrylic. The triangular clasp. The form is in a form of a triangle. It takes advantage of the interdental area more so between the first and the second premolars, and the two sides of the triangle seem to abut the distal undercut of the first premolar and the mesial undercut of the second premolar. And since this triangle is open, the open end is towards the distal side. This is very useful, and an additional clasp which is at times given along with the Adams clasp for better retention of the acrylic plate. Then we have the ball end clasp. We do not make this. This is available, and then we just use it where it needs to be used, more so between the first and the second premolars. And an appliance where it is most commonly used would be its use in the twin block appliance, where this ball end clasp is made in between and adapted to the lower central incisors, and at times between the maxillary canine and the maxillary first premolar. This is for added retention. Then we have the Schwartz clasp. If you look at this design, this appears more so as an arrowhead, but you require certain pliers for this, the Schwartz pliers, to make this particular type of a clasp. So we have the single arrowhead clasp, as you can see in the diagram here. It seems to engage the interdental undercut in between the first and the second maxillary molar. Or you can also have a continuous arrowhead clasp which can engage the interdental area between the first and the second premolar, between the second and the first molar, and between the first molar and the second molar. Then we have the Adams clasp, which is sort of a modification of the arrowhead clasp. This is a very versatile clasp, and this is the clasp which is used most often. Why so? Because it can be used on deciduous teeth, as also in permanent teeth, as also in teeth which are semi-erupted. It takes its retention from the mesiobuccal and the distobuccal undercuts. And then the wire moves over the occlusal embrasures and ends as retentive tags in the acrylic. There is a bridge for this Adams clasp, which is supposedly 45 degrees to the buccal surface of the molar. There are a lot of modifications of this anterior Adams clasp. You can do this anterior Adams clasp on just one tooth in the anterior region, or you can combine it with two teeth, etc. There are other modifications of the Adams clasp. As I've just mentioned, there is a bridge for the Adams clasp, and you can make an additional arrowhead which can engage the mesial undercut of the second premolar, and this additional arrowhead is then soldered to the bridge. So the bridge can hold this soldered joint. One little advantage for added retention. Or as you can see in the second diagram, a hook, a J hook, can be soldered to the bridge, or you can incorporate a helical coil in the bridge itself as you are fabricating the Adams clasp. And if you see the fourth diagram, you can also incorporate a distal extension hook for the purpose of attachment of elastics. Or a buccal tube can be soldered to the bridge for you to use the face bow, namely the inner bow of the face bow is placed into the soldered buccal tube in certain scenarios where you desire such a thing. And you can see in the other figure that there is just one arrowhead which seems to be seated in the mesiobuccal undercut. But on the other side, if it is difficult for you to make an arrowhead, you can just curve it around the tooth. Another advantage of this versatile Adams clasp is that you can also carve the gingival area a little bit well in the cast such that your mesiobuccal and the distobuccal undercuts are well seen and well held by the mesiobuccal and the distobuccal arrowheads. So if you see any appliance, a removal appliance, if you have to wear it, it requires good retention. Otherwise the patient is not going to wear it. And if the patient is not going to wear it, then you're not going to get the desired tooth movement. Hence, if you're going to make an Adams clasp on the first molars, you also need an additional clasp, which could be a triangular clasp or a ball and clasp, which is fabricated in between the first and the second premolars. So that helps to hold the appliance in its place and bring about the desired tipping movements. We have the south end clasp, which is a wire which is modified to the cervical region of the two central incisors, dipping in the middle to accommodate the interdental papilla. This is also for some additional retention in certain appliances instead of the Adams clasp, which could be a little unsightly. This could be used, which could be a little bit aesthetic. Then we have the delta clasp. We all know twin block appliance normally uses this type of a clasp because in an Adams clasp, due to repeated adjustment of the clasp, it could fracture, whereas this is more resilient and it stays put until the end of the active twin block treatment. So most commonly used during the fabrication of twin block. But then even an Adams clasp could be used in place of a delta clasp for the fabrication of a twin block functional appliances. So the Duising's clasp is another clasp which is fabricated in the following manner, where the wire from the distal surface of the tooth seems to curve above the greatest circumference of the buccal surface of the molar, recurves upon itself, and then ends at the distal undercut. Similarly, on the mesial side too, the wire curves above the greatest circumference of the buccal surface of the first molar, recurves upon itself, and rests in the mesial undercut for added retention. Then we have the eyelet clasps, which are fabricated in the form of eyelets. It could be a single eyelet, a double eyelet, or a continuous eyelet. Now, we shall go on to the active components. So far, we have dealt with the base plate, which seems to have harbor the retentive components, namely the clasps. So you can choose the clasp according to your convenience, whichever one you feel is good and is ideal for the particular case. Now we have the active components, and springs are an active component of the removable appliance. So in springs, we have the self-supported springs, which we call as the buccal canine retractor. Well, the canine retractors too can be called as springs. So a self-supported buccal canine retractor is made up of 21 gauge or 0.7 millimeter stainless steel wire. The self-supported are of two types. They are supported, or why they are supported? Because if it's made out of 0.5 millimeter stainless steel wire, it requires a sleeve or a tubing to support it, or it could be stabilized. For example, if you're going to use a buccal canine retractor and then you want to stabilize it, then the distal arm, from that distal arm, you can use a wire and solder it to the bridge of the Adams clasp, so that be a little bit stabilized. Then we also have the helical loop or the reverse loop canine retractor, which is made up of 0.7 millimeter stainless steel wire. We have the U-loop canine retractor, which is made up of the 0.7 millimeter stainless steel wire, and we have the coffin spring, which is made up of 1.25 millimeter stainless steel wire. We have the guided springs, which are the cantilever springs, made up of 23 gauge or 0.5 millimeter stainless steel wire. These cantilever springs are of two types, namely single cantilever and double cantilever. Then we have the finger springs, which are made up of 0.5 millimeter stainless steel wire. We have the palatal canine retractor, which is made up of 0.5 millimeter stainless steel wire. Then we have the T-springs, which is also made up of 0.5 millimeter stainless steel wire. Then we also use the auxiliary springs like the apron springs, which are made up of 0.35 to 0.4 millimeter stainless steel wire, which are used in conjunction with a high labial bow. I shall show you how all these springs function and way to use them and how to fabricate them. So we all know that the normal pressure which is given to a tooth should be around 20 grams per square centimeter of root area. If you're going to give a little bit more force, then you're going to have something known as an undermining resorption. So we prefer a frontal resorption during the tipping movements which are produced by the removable appliance. So here we have a formula which goes as such. Deflection is directly proportional to pressure cube of the length of the wire and inversely proportional to the fourth power of the diameter. So if you take any wire and if the diameter is doubled, then the deflection decreases by 16 times. If you take a wire and you double the length, then the flexibility of that wire, namely the spring, increases by 8 times. And if the pressure is doubled, then the deflection is also doubled. So we need to know that deflection is directly proportional to the pressure, the cube of the length of the wire, and inversely proportional to the fourth power of the diameter. This we need to bear in mind such that the forces that we give are normal, low, continuous forces. A spring. So we would like to know what are the parts of a spring. If you look at the diagram at the right side, you would see that any spring has got 3 parts. It has an active arm, a coil, or we call it a helix, and a retentive arm which is immersed in the acrylic base plate. This helix needs to be at least 3 mm in internal diameter. Where is it placed? Very important. To be positioned opposite to the direction of intended tooth movement. It is placed along the long axis of the tooth to be moved, and most importantly, perpendicular to the direction of tooth movement. If you do not place it in this fashion, then your teeth would not be in the intended direction of tooth movement. So these finger springs are made up of, as we already discussed, out of 23 gauge wire, right, or 0.5 mm wire. Hence they need to be guarded or guided or boxed, otherwise they'll get distorted. And how it is activated? By opening the coil by about 3 mm. Care to be taken to see that the active arm is below the helix or the coil, such that it encompasses the tooth. So here, as you see, it's a finger spring. I've just mentioned to you where it's supposed to be placed, and these finger springs can be used one on either side of the maxillary central incisors in order to close the gap in between the maxillary central incisors. So we have a spring which could move the tooth mesially, and we have another spring on the other side which would also help to move it mesially, and then you close the maxillary median diastema. Very useful in certain cases, and undergraduates could make this particular spring along with your retentive clasps and deliver a removable appliance and do a world of good for the patient in a very simple way. We have a cantilevered spring. We call it the single cantilever or the double cantilever. So in the double cantilever, we have 2 helices. So we need to see to it that the active arm is almost perpendicular to the tooth surface, namely the lingual surface of the instanding incisor. Most commonly used to correct an anterior crossbite. It could be one single tooth which is an anterior crossbite, or 2 teeth which are in anterior crossbite. If it is a single tooth in anterior crossbite, you can use a single cantilever, and if 2 teeth are in anterior crossbite, you can use a double cantilever. So more the helices, the greater the flexibility of the wire, the greater the resiliency, and you can deliver ideal forces to the tooth. And an anterior crossbite can be very well corrected with a simple spring along with the use of your retentive clasp and your acrylic base plate, as also to take care to see that you have a posterior bite plane incorporated such that your anterior crossbite is corrected effectively without any obstruction. So as I said, these springs need to be either guided or guarded. Others will tend to spring, and if they are not properly seated against the lingual surface of the teeth, they are not going to deliver the force. So at times, we need to give a guide. So here you can see a double cantilever spring, which is used to procline the retroclined maxillary anteriors. But you have a guide such that the spring does not get distorted. You can also box it, and if you box it, then the spring lies in the recess between the acrylic and the palatal surface of the maxillary arch, so that it is not distorted and gives its intended force to the teeth in question. Well, this is a T-spring which could be fabricated to move a tooth buccally, more so the instanding first or the second premolar. A different modification known as the mattress spring, which could serve a purpose very similar to that of your single cantilever spring, but without the incorporation of the helix. But here the wire is increased in length, hence it is giving it its flexibility and its resiliency. Then we have the coffin spring, but though we call it a spring, this particular spring is made up of 1.25 millimeter stainless steel wire. That's a thick wire, but then it is made into an omega loop, and the ends are incorporated into the acrylic on either sides, and then we can adjust this omega loop, expand it a little bit, used more so for the purpose of expansion of constricted maxillary arch. But then this is not used so much because we have better appliances to bring about correction of constricted maxillary arches. But then, so far as the undergraduates are concerned, this is taught, and it is better that you know what a coffin spring is, but it may not be used that much in today's scenario. Then we have the palatal canine retractor. This is used if you want to distalize the maxillary canine. So if you already have a case where your maxillary canine is nasally tipped, then it is a very ideal case for you to just distally tip it with the help of this palatal canine retractor. But then, if your maxillary canine is buccally placed, then you have to use a buccal canine retractor. Normally, the active arm of any spring is below the helix, but it is only this particular buccal canine retractor where the active arm is above the helix. This is used for you to retract the buccally placed maxillary canine slightly distally and little palatally. If you remember, I would have just mentioned stabilized springs. In this case, if you feel that this particular buccal canine retractor is a little unstable, then the other arm which you see, which is encompassing the distal surface of the first premolar, to that arm another wire can be soldered to it, and the other end of the stainless steel wire can be soldered to the bridge of the Adams, and hence this makes it a stabilized buccal canine retractor. Normally all springs are made up of 0.5 millimeter stainless steel wire, whereas the buccal canine retractor is the only one which is made up of 0.7 millimeter. Hence, by any chance, if you were to use a 0.5 millimeter, then it is better that you stabilize it or give a sleeve or a tubing to the distal arm of the buccal canine retractor. Then we have the reverse loop canine retractor, which is mostly used to retract the mandibular canine. And why so? This particular reverse loop is got a fabrication such that it is not too long. Hence, it is suitable for the mandibular arch because the sulcus is a little bit shallow in the mandibular arch. Hence, this particular modification of the canine retractor, namely the reverse loop, could be used for the mandibular arch for you to distalize the mandibular canine. Of course, you also have the U-loop canine retractor, a different modification of the buccal canine retractor with the helix. Here we do not have the helix. Here the U-loop can be activated for you to retract the canine and bring it into the mild space which would be present distal to it. I might have mentioned to you apron springs, but we do not use this as of now so much. But if it were to be used, then you require a high labial bow, which could be made out of a 0.9 millimeter or 1 millimeter stainless steel wire, which is high in the vestibule, and from there you can wind the apron springs, which is made out of 0.3 or 0.4 millimeter stainless steel wire, and then it hangs as an apron for you to give selective force on the, for example, it happens to be a labially proclined lateral or just a labially proclined central. You can activate it such that it gives selective force to one or two teeth. So dear viewers, with this we conclude the part 1 of removable appliances, where I have thrown light on the retentive components, namely the different types of clasps, as also the spring component, which is the active component of the removable appliance. The other active components, namely the labial bows as also the screws, shall be dealt with in the part 2 of removable appliances. Thank you for a patient listening.